Welcome to part 4 of our Pulmonary Disorders series. In this final chapter, we shift focus from the airways and vasculature to the surrounding structures, environmental triggers, and developmental origins of lung disease. We'll explore the pleura, the delicate membrane that can host life-threatening conditions like pneumothorax and empyema. Then we dive into occupational and environmental lung diseases, conditions caused not by viruses or genes, but by our jobs, homes, and even the air we breathe. Next, we cover neoplastic lung diseases, including primary lung cancers like adenocarcinoma and small cell carcinoma, as well as rare tumors and metastases. And finally, we journey back to the beginning, looking at congenital and developmental lung disorders, those that begin before birth but impact life from the very first breath. This part is built around real clinical cases, helping you recognize red flags, link pathology to symptoms, and sharpen your diagnostic reasoning. Let's begin with pleural disorders, the interface between lung and chest wall, where breath can be lost or saved. Let's begin with pleural disorders, where pathology affects the thin, double-layered membrane surrounding the lungs. The pleura plays a crucial role in smooth lung movement and pressure balance. But when disrupted by fluid, air, infection, or malignancy, it can lead to significant respiratory compromise. We'll cover 5 key pleural conditions. Pleural effusion, when fluid accumulates, leading to compression and breathlessness. Causes range from congestive heart failure to malignancy and infections like TB. Spontaneous pneumothorax, often in tall, young males or patients with underlying lung disease. Air enters the pleural space, collapsing the lung partially or completely. Tension pneumothorax, a life-threatening emergency with rising intrathoracic pressure that compresses the heart and opposite lung. Immediate decompression saves lives. Empyema, infected pleural fluid, often following pneumonia, requires drainage and prolonged antibiotics. Mesothelioma, a rare but aggressive cancer tied to asbestos exposure, often presenting with chest pain and pleural thickening. For each case, we'll connect clinical clues with pathology, diagnostics like imaging and pleural taps, and walk through treatment pathways, from conservative management to chest tubes and surgery. Understanding pleural disorders means thinking beyond the lung, recognizing how what surrounds the lung can just as easily impair gas exchange and threaten life. Let's walk through the cases. Pleural effusion. An elderly man presents with breathlessness and dull chest pain. Exam reveals dullness to percussion and decreased breath sounds. Imaging shows fluid in the pleural space. This is a classic pleural effusion, commonly caused by heart failure, infection, or malignancy. Initial step, thoracentesis, to determine if it's transudate or exudate. Manage the cause and drain if symptomatic. Pneumothorax, spontaneous, a tall, thin young man suddenly develops chest pain and breathlessness while watching TV. On exam, breath sounds are reduced and the chest is hyperresonant. This is likely a spontaneous pneumothorax. Small ones may resolve with observation, but larger ones need aspiration or a chest tube. Tension pneumothorax. Following trauma, a patient crashes. Trachea deviates, neck veins distend, and breath sounds vanish. This is a medical emergency. Tension pneumothorax. Don't wait for imaging. Do an immediate needle decompression, followed by chest tube insertion. Empyema. Despite antibiotics, this patient has fever, cough, and pleuritic pain. Ultrasound shows loculated pleural fluid. Diagnosis. Empyema. Management includes chest tube drainage and prolonged IV antibiotics. A shipyard worker presents with chest pain and weight loss. Imaging reveals a pleural mass. Biopsy confirms mesothelioma, an aggressive tumor linked to asbestos. Treatment is palliative with chemotherapy and possible surgery. Now, let's turn to neoplastic lung disorders, where uncontrolled cell growth transforms the lung from a vital organ of gas exchange into a site of malignancy. Lung cancer is one of the leading causes of cancer death worldwide, often diagnosed late due to subtle or absent early symptoms. We categorize primary lung cancers into 2 broad types: non-small cell lung carcinoma, NSCLC, which includes adenocarcinoma, the most common type, especially in non-smokers, often peripheral in location. Squamous cell carcinoma, usually central, strongly linked to smoking, and may cavitate. Large cell carcinoma, aggressive and poorly differentiated. Small cell lung carcinoma, SCLC, fast-growing, centrally located, and notorious for early metastasis and paraneoplastic syndromes like SIADH or Cushing's syndrome. Beyond primary cancers, the lungs are also a common site of metastasis, from breast, colon, renal, or other cancers. Patients may present with persistent cough, hemoptysis, or chest pain, unintentional weight loss or systemic symptoms, pleural effusions or signs of local invasion, like hoarseness or SVC syndrome. Diagnosis relies on imaging, chest X-ray, CORT, and PET scans, followed by biopsy and histopathology. Staging, TNM system, guides treatment. Management options include surgery for localized NSCLC, chemotherapy and radiotherapy for more advanced disease, and targeted therapies or immunotherapy based on genetic mutations. Lung cancer is not just a disease of the lung, it affects the entire body and requires a multidisciplinary approach. Let's explore real-life cases that bring these neoplastic conditions to life, linking symptom to stage and treatment to hope. Adenocarcinoma. Our non-smoking woman presents with weight loss and cough. CT shows a peripheral mass, most likely adenocarcinoma. Biopsy and molecular profiling guide therapy. Surgery if localized, targeted therapy if mutations like EGFR are present. Squamous cell carcinoma. A smoker presents with hemoptysis and a central mass. Hypercalcemia due to PTHrP is a giveaway. This is squamous cell carcinoma. Surgery is possible if caught early. Later stages require chemo and radiation. Small cell lung cancer. A smoker with facial swelling, confusion, and a central mass suggests SVC syndrome and SIADH. Diagnosis: small cell lung cancer. Surgery is not an option. Chemotherapy and radiotherapy are the mainstays. Carcinoid tumor. A patient presents with flushing, diarrhea, and wheezing. Bronchoscopy shows a vascular central tumor, likely a bronchial carcinoid. These are slow-growing and surgically resectable. Lung metastases. A breast cancer survivor now has multiple bilateral lung nodules. These are metastases. Focus shifts to treating the primary malignancy and palliation. Let's now explore environmental and occupational lung diseases, conditions caused not by genetics or infections, but by the air we breathe and the substances we're exposed to over time. These disorders remind us that the lungs are frontline organs, constantly interacting with the external environment, and vulnerable to toxic particles, fumes, allergens, and dust. We'll look at several key categories: pneumoconiosis, chronic fibrotic lung diseases caused by inhaled inorganic dusts; silicosis, from silica exposure in mining or construction; coal workers' pneumoconiosis, black lung, from coal dust; asbestosis, from asbestos exposure in shipyards or insulation work, linked to mesothelioma and lung carcinoma; hypersensitivity pneumonitis, also called extrinsic allergic alveolitis, a result of inhaling organic antigens like moldy hay, bird droppings, or humidifiers. Leads to immune-mediated inflammation of the lung parenchyma. Occupational asthma, triggered by workplace allergens like flour, latex, or isocyanates. Can be reversible early on, but disabling if persistent. Byssinosis, Monday fever, seen in textile workers exposed to cotton dust. Chemical exposure injuries, including acute inhalation of chlorine, ammonia, or smoke in industrial or fire settings. Clinically, these disorders often present insidiously, with symptoms like chronic cough, progressive dyspnea, or wheezing. Diagnosis requires a detailed occupational history, chest imaging, and sometimes lung function testing or biopsy. Management focuses on removing exposure, using corticosteroids or bronchodilators where indicated, and supporting respiratory function through rehabilitation or oxygen. These diseases aren't just clinical, they're social and economic, reflecting the importance of occupational safety, regulation, and awareness. Let's now walk through patient stories where work and environment became the root of disease. Asbestosis. A retired construction worker develops breathlessness and has pleural plaques on imaging. This is asbestosis. No cure. Manage symptoms and monitor for mesothelioma. Silicosis. A sandblaster with upper lobe nodules and eggshell calcification likely has silicosis. Key management: avoid exposure and screen for TB. Coal workers' pneumoconiosis. A coal miner develops dyspnea and shows upper lobe fibrosis. This is coal workers' pneumoconiosis. Management is supportive. No specific treatment available. Berylliosis. An aerospace engineer presents with symptoms mimicking sarcoidosis. Imaging shows granulomas. This is chronic beryllium disease. Treat with corticosteroids. Hypersensitivity pneumonitis. A farmer has sudden fever and cough after exposure to moldy hay. Think hypersensitivity pneumonitis. Remove the antigen, use steroids if needed. To complete our journey through pulmonary disorders, we now explore developmental and congenital lung diseases, those that arise before birth and affect life from the very first breath. These conditions are rooted in abnormal embryologic development of the airways, lungs, or pleura. Some are discovered in infancy, while others may remain silent until adolescence or adulthood. Let's walk through key examples. Pulmonary hypoplasia, underdevelopment of lung tissue, often associated with congenital diaphragmatic hernia, oligohydramnios, or renal anomalies. It leads to severe respiratory distress at birth. Congenital diaphragmatic hernia, CDH, abdominal organs herniate into the chest due to a defect in the diaphragm, compressing the lung and impairing development. Congenital pulmonary airway malformation, CPAM, a cystic lesion replacing normal lung tissue, often diagnosed prenatally or in early childhood with recurrent infections. Bronchopulmonary sequestration, a portion of lung tissue that receives blood supply from systemic circulation and doesn't communicate with the bronchial tree. Tracheoesophageal fistula, TEF, abnormal connection between the trachea and esophagus, leading to feeding difficulties, coughing, and aspiration in newborns. Primary ciliary dyskinesia, Carter-Hennes syndrome, a genetic disorder of motile cilia causing impaired mucociliary clearance, leading to recurrent infections, sinusitis, and bronchiectasis. Diagnosis may involve prenatal imaging, ultrasound, MRI, postnatal chest X-rays, CT scans, or bronchoscopy, and genetic or functional testing, depending on the condition. Management strategies range from neonatal resuscitation and ventilatory support, surgical repair, as in CDH or TEF, to long-term respiratory care for chronic infections and reduced lung function. Recognizing congenital and developmental lung disorders requires a keen understanding of embryology, imaging, and pediatric care. Let's now explore cases that bring these disorders to life, starting from birth, and sometimes even before. Pulmonary hypoplasia. A newborn from a pregnancy with oligohydramnios has severe respiratory distress. Imaging confirms underdeveloped lungs, pulmonary hypoplasia. Treatment is supportive, often with poor prognosis. Congenital diaphragmatic hernia. A newborn with respiratory distress and a scaphoid abdomen has bowel loops in the thorax. This is a diaphragmatic hernia. Intubate, stabilize, then surgically repair. CPAM. An infant with recurrent infections has a multicystic mass on imaging. CPAM is likely. Treatment is surgical resection. Bronchopulmonary sequestration. A child with recurrent pneumonia has a lung lesion with systemic arterial supply. Diagnosis: bronchopulmonary sequestration. Management is surgical removal. Cystic fibrosis. A child with failure to thrive, greasy stools, and recurrent infections likely has cystic fibrosis. Diagnosis is confirmed by sweat chloride test. Treat with airway clearance, enzyme replacement, and CFTR modulators. And with that, we conclude part 4 of our Pulmonary Disorders series, where we've explored the intricate spectrum of pleural diseases that encase and restrict the lungs, neoplastic conditions, where uncontrolled growth disrupts function and threatens life, environmental and occupational disorders, shaped by what we inhale at work or home, and developmental or congenital lung diseases, rooted in early life and anatomy. These conditions remind us that lung health is influenced not just by biology, but by environment, occupation, development, and chance.